Let people file in here for a moment. And we're joined today by Dr. Amos Song on a beautiful Seattle May Day, which is kind of rare in this part of the country. We do have a lot of PTs that are going to be from all over the country that find us via the Facebook physical therapy group, which is a group that I run, about 15,000 physical therapists around the country that are on that. So welcome to all those folks. But we're excited to bring Dr. Amos Song today. He's at the physical medicine and rehabilitation specialist in Bellevue and in Issaquah at the Overlake Clinics, and works as part of their sports medicine team. Kind of quick background on him, and it's a lengthy one. Like I was joking beforehand, is that his resume, reads like a 40-year practicing sports medicine physician. Great trajectory to the start of his career. He completed his undergraduate work at Cal Berkley and picked up a master's of medical science at Boston University. So kind of hit both coasts, then continued up the coast or down the coast. Went to Tulane University for School of Medicine. Graduated there in 2017. Had fellowships at Montefiore in Medical Center in the Bronx in New York, and also trained at Vanderbilt University. Dr. Song is a favorite of our PTs just because he's collaborative and he's innovative, and also he's a place where physical therapists can easily send a client that is not necessarily a surgical candidate, but needs someone to kind of run point and help manage the case or order diagnostics in the form of a lot of different ways, whether it be ordering an MRI or diagnostic ultrasound. Or are there some more advanced? While in he covered football, basketball, soccer, and also was on the sideline for MLS, for the New York City FC, and he also helped out provide coverage for the New York City Marathon. So we got a lot of marathon runners that will likely hear this and be on the call as well. We're excited to have you here today. So welcome, and let me know if there's anything that I got wrong there.
Oh, no, that was great. Thank you for having me. Excited to be here.
Well, I think we'll do this kind of like we usually do, and that is for the audience, is that Dr. Song's got a few slides prepared of a talk that he kind of created for us here, and then if you have questions, there's a Q&A button that any participant can kind of click on. I'll be kind of watching those. And then we have some questions that people send in ahead of time. We'll kind of get those answered at the end. So we're hoping to wrap up before the hour. So again, thank you for everybody taking time out of their day. I know everyone's super busy. The weather's great. So whether you're listening to this live or listening to it later, we appreciate you kind of participating and helping all clinicians and all patients kind of raise the level here in Seattle.
All right, so I'm just going to share my screen here. Does that look okay, Ben?
Yeah, and you want to go to the slideshow at the top there of your PowerPoint. And then
how does that look?
Yeah, you should have a slideshow like presenter view, or
still not. Let me try. How about that?
Got it. Nailed it.
All right. Yeah, you would think by now I'd know how to use Zoom, but still a challenge here, huh?
Well, you're
all right.
You're focusing on your career. Focus on your career and on your patients, and not on Zoom. That's fair. Right?
Yeah, I'm here. So my name is Amos Song again. Happy to be here. I really appreciate you guys having me. So I'm talking about chronic tendinopathies today. I won't go too much into this. There's my address and phone number for my clinic there if you need it. But I did join Overlake recently, about 7 months ago, October of 2022.
So lost your share there just a second. That's
Oh,
right.
how are we? We're still off? Oh my goodness. Let's try it again. Are you back?
Back. You got it.
Okay. Try to click next. So no financial disclosures for this talk. And so I think the thing about tendinopathies are they're super common. Here, this is uh, some numbers based from 2013, and it shows that millions and millions of patients are dealing with tendinopathies in the United States alone. Wherever there's a tendon, there seems to be the possibility for tendinopathy or disease of the tendon, whether it's the shoulder and rotator cuff, and the hip flexor, glute medius, glute minimus as well, hamstring, Achilles, plantar fascia. We'll throw in there. Not fascia is obviously not a tendon, but that as well. Patellar tendon, especially in our jumping athletes, quadriceps tendon, and then way more tennis elbow than golfer's elbow, but we do see that in the elbow as well. And so, just briefly as a review, what is a tendon? So the tendon is the piece of soft tissue that connects muscle to its bony attachment. And any time that muscle contracts, it pulls on the tendon and it allows that bony attachment and that joint to move, as you can see in this cartoon here. And so these tendons get pathologic, anytime there's enough mechanical load that the tendon can't recover from. And so here we have this physics graph here that kind of gives me nightmares, but we have stress on the y-axis and strain on the x-axis. And so up to a certain point, we can put stress on our tendon and it responds really well. But you can see the slope here start to flatten out when we get to a certain level of stress, and it just doesn't respond as well to that stress. And we eventually get microscopic failure, small tears that we may not be able to see on our imaging or something like that. But and eventually, if we get to a certain point, the tendon can tear completely. And of course, at that point, you're not sending them to me. We're talking to the surgeons to get that tendon back together. But sometimes if we hang out too much here in the microscopic failure level here, we don't get a good healing response, a failed healing response, according to Cook et al. And I kind of think about it as when you see that hourglass on your computer when it freezes, we kind of get stuck there. And so what do we see when we take some tendon cells, we look at it under a microscope when we're dealing with chronic tendon issues? So one of the things that we notice is we get collagen disorganization. So normal healthy tendons have very straight, well-organized type 1 collagen. It's strong and it's doing its job. But when we get into that failed healing mode there, we get a lot more type 3 collagen, which is a precursor. It's not as straight, it's not as strong, it's brittle, and it's a lot weaker than our normal type 1 collagen. And this is a kind of a microscopic view of that. And figure A here is our type 1 collagen. The arrows are pointing towards tenocytes there. You can see how well organized this is. It looks like, sorry for the people who are eating lunch, but nice strips of bacon here, and it's really nice, nice and well organized. Look at B, our type 3 collagen. You can see how it's there's tenocytes everywhere as well, but there's also kind of that organization is lost, and it kind of looks like raisin bread. We also see when we have chronic tendinopathy is a phenomenon we call neovascularization. So again, in this figure B, this letter V corresponds to vessel or blood vessel. So we get blood vessels going into that tendon, probably as a healing response, and with the blood vessels, nervous tissue grows in there as well, and that's thought maybe that's why it's so painful. And then this is another histological slide of that neurovascularization process. In figure A, we have our normal tendon and there's no blood vessels or anything like that. But we look at B here, and this, again, the letter V for vessel, we see blood vessels, and then the stain here is staining for neural tissue, and you can start to see ingrowth of nervous tissue. And one of the words I haven't mentioned yet is inflammation. And for a long time, we were calling things, tendonitis, itis for inflammation. And we really don't see, in chronic tendinopathy, histological evidence of inflammatory cells and normal inflammatory markers. And so sorry this got cut off here, but basically the most significant feature in tendinopathies is the absence of inflammatory cells, and we kind of see more of this disorganized degenerative process instead. And so the phrase tendonitis, again, itis for inflammation, has kind of fallen out of favor, and nowadays we like to refer to chronic tendinopathies as tendinosis or tendinopathy, which is kind of a broader term of pathology of the tendon. And I think that research is still ongoing here in the histology of tendinopathy. Bring up this really complicated looking science slide here, so to speak. But basically to say that, there may be a role of both inflammation and degeneration, but definitely for the most part, it is a degenerative process rather than a inflammatory process. That's not to say that early on, when we kind of that acute phase in the first 24 hours, 6 weeks or so, we may have some acute inflammatory markers when we first hurt that tendon. But once we get to 6 weeks or so, and then the tendon starting to repair itself, we're seeing less and less inflammatory markers. And so I use a lot of diagnostic ultrasound in my clinic. I think it's a real great way to visualize these tendons here, and we see some of the same findings that we see in histology on our ultrasound. So we see thickening of the tendon, as you can kind of see here. This is a patellar tendon. This is going to be more proximal, and this is that patella, this white line here, and then this is more distal. And you can see how much thicker it is here, where it's pathologic, compared to a little bit more distal, where it's a lot thinner. And then you can see how the collagen fibers, you can see it kind of, I tell patients, it looks like a rope or the end of a broomstick. But when we get pathology, we start to lose that organization. We also see that neurovascularization phenomenon that we talked about, and you can see that in figure C here. I turn on the Doppler, which looks for blood flow, and I see blood flow where there shouldn't be blood flow, and there's blood flow, as you can see here, in this tendon. The other things that we see when we ultrasound tendons are cortical irregularity, meaning again, that tendon attaches the muscle to the bone, and so wherever it attaches to the bone, we can see that bone losing its nice normal contour, and it looks bumpy. So this patella looks pretty good here. It's nice and linear. There's no kind of ragged edges, but that's what we see if we did see cortical irregularity. And sometimes we can get calcifications within the tendon. I've seen this in pretty much every single tendon that can be pathologic, I guess, but definitely seen them in the rotator cuff. But this thought that that the calcifications occur as kind of the tendon's trying to heal itself, and then the stem cells kind of go haywire, and they build calcium instead of the tendon tissue that they're trying to rebuild. This is a sort of a quote unquote real life patient that I saw not too long ago, but you can kind of see just how thick that tendon can be when it's pathologic on the ultrasound compared to the normal size on the right here. It's this, and then this is that the right where that Achilles tendon attaches onto the calcaneus. And again, the bone should be nice and smooth, have a contour like this. But as you can see, right at the insertion, it's starting to get a little bit ragged there at the most distal insertion. And again, you can see the nice organized fibers a little bit more proximally, but when we go distally, we see kind of, little black holes in there, and that's definitely representative of that tendinopathy. I'm gonna hope this video is playing. Yep, and then this is that tenosynovitis again. That same patient, you can see that ingrowth of blood vessels. Shouldn't be blood vessels in the tendon, but with some color Doppler, we can kind of pick that up. And so when we have tendinopathies, what are our treatment options? We can have them just rest, modify their activity. We can definitely try to use, some non-steroidal anti-inflammatory drugs and Tylenol to manage, mostly symptoms. And then by the time that they see me, they've either already seen physical therapy or they're thinking about it. And I absolutely, when patients come to me with a tendinopathy, I absolutely start them uh, with physical therapy. And I guess I'm preaching to the choir here, but I think that's absolutely the way to go. And I think the first thing is the effect of exercises, and especially eccentric exercises have great evidence for remodeling the tendon fibers themselves. And so um, I'm not going to try to pretend to tell a bunch of PTs what an eccentric exercise is. That conversation should go the other way. But this is a little diagram of the Achilles tendon there. And that Alfredson protocol was kind of the first landmark paper, I think, regarding this.
Right.
Um,
That was a big one for PTs, and now there's, as you've probably seen online, there's lots of debate on how to
on
dose, how frequency, intensity. It's
right, right,
a hot PT debate topic for sure. I don't have
right,
a
because
I don't have a
Alfredson
horse in
was
the race.
pretty
Yeah.
right. Alfredson was pretty heavy duty, from what I can remember. Um, and so on the left, that's where they start, and then usually kind of when either after PT or they quite haven't started PT, that's kind of when they start to see me in clinic. And for a long time, we were kind of the best tool we had in our toolbox as a physician. That's non-operative. Was injecting these tendons either into the tendon or right next to the tendon with steroid medication. But there were some issues with that. And the first thing that we noted was that these steroid medications are tenotoxic. They're bad for the tenocytes. They're not healthy for them. And so, and of course, repeated steroid injections into a tendon over the long term can definitely put patients at risk for rupture of that tendon. And then the other thing that's a limitation of steroid medications is that it's a short-term treatment. I kind of cite the ballpark of 6 weeks to 3 months to patients. So if that happens, I'm stoked, and I'm happy if that happens. That's not to say that I never use steroid injections in tendons. Sometimes I'll still do that. Sometimes I'll do it because they want to continue PT, and they're just having such difficulty with pain that I'll use that kind of as an adjunct, but definitely not a sustainable or a long-term solution there. And And then the other thing is, kind of went into that whole thing in a couple slides ago about how this chronic tendinopathy is not an inflammatory process. And so, does it make sense for us to put a steroid, an anti-inflammatory medication for a disease process that's not inflammatory? Does that make sense? And so, because of that, not we, but people a lot smarter than me have, brought up something called a needle tenotomy. And that needle tenotomy is a way to help remodel that tendon, that type 3 collagen that I was mentioning earlier. How can we get rid of that type 3 collagen and replace it with type 1 collagen? We know that the eccentric exercises, we know that that helps that process along. But if that's not successful, is there anything else between physical therapy and a surgical intervention that can help these tendons? Um, and so this needle tenotomy has now developed into what we call percutaneous through the skin, ultrasonic, based on ultrasound, needle tenotomy. What this device is that it, I mean, they came up with this in the 70s, and they were using it to treat cataracts, putting this in people's eyes, believe it or not. And this needle has a vibrating metal tip. It vibrates at a certain ultrasonic frequency that vibrates, and it fragments that uh, type 3 collagen that's not as strong, that's not as healthy. So it breaks that apart while keeping that type 1 collagen intact. This needle device has a irrigation system with saline, and so so the saline is aspirating that debris as it's fragmenting that type 3 collagen, while leaving the type 1 collagen healthy and intact. So an analogy for that is that this opera singer that can break the wine glass if she sings at a high enough frequency. So that it's not so the frequency is optimized to break the glass, but it's not like breaking the table that's on it or anything like that. And so that's what they mean when they say this device is tissue selective. Tenex is the company that I utilize, and then TenJet works in a little bit of a different way, but that's their main competitor. And again, kind of a little bit of a diagram of how that works, and then a little bit of zoom in of the tip there. This tip is really not that sharp, and so it actually doesn't, cut through skin very well. So I have to make and I'll show you a video later, but I have to make an incision before I can actually push this device through. And again, it's just, yeah, it's not very sharp, but that tip moves at a back and forth movement at a certain optimized ultrasonic energy, while saline is continuously irrigating and aspirating the debris there. So this is a video. If I can get this to play. There we go. So we make a small puncture. This is an elbow, a lateral epicondylosis case. We make a small puncture with the needle. That micro tip, it's about 1 inch long, width of an 18 gauge needle. We put it into the tendon where it's pathologic. The necrotic tissue is down here in the black. And then this device will irrigate with saline, as you can see here, and it'll go back and forth as I press on a foot pedal, and it'll debride that necrotic tissue as it aspirates. The step that's not seen here, I do this all under local anesthesia. We kind of just inject some ropivacaine probably in that area. And we do offer some conscious sedation at the surgery center there in Bellevue where this takes place, but just local anesthetic is the majority of cases. This is a paper here showing this process under this Tenex procedure. I'm going to And I'm showing this just to show that we do this procedure all under ultrasound guidance so that we know exactly where all our instruments are going. And so step A is that scalpel procedure. You can kind of see this triangular shape there. That's the scalpel. And again, that Tenex tip doesn't really cut very well, so we use the scalpel instead, kind of a quick stab incision, and then here's that Tenex device going in. And that's a device at work. I tell patients, that the post-procedure rehab is absolutely critical because, we've taken out that type 3 collagen. We're trying to get this type 1 collagen to come back. And if you're in the post-procedure rehab is crucial. And so the first couple days we have patients, just trying to manage pain really. I usually put, ankle and foot procedures in a boot, maybe some crutches if we did the knee or the hip, a sling for the elbow or shoulder. And I kind of have this slow progression, and I'm hoping, by week 6 or so, we can kind of work our way towards some more eccentric exercises. And then that's about when I'm hoping to see some improvement in symptoms. And so this is a study here, a prospective study for common extensor tendinopathy. And we can see pain scores that that decrease again by 6 weeks. Again, that's when we, that's that time frame when I hope to start to see some pain improvement, and that's kind of correlated by the studies here. And again, we can see follow-up visits at 3 months, 6 months, and 12 months, and they kind of have sustained pain relief. And if you think about, again, that steroid injection, which was what we were doing previously, if I'm hoping for 6 weeks to 3 months, by the time we get here, their pain is probably back to, where we started. And so I think that's one of the main advantages of this needle tenotomy procedure.
And that's
Um,
and just to interrupt real quick too, I think that slide's pretty great because it seems like tendinopathies in general, it's 100% people's functions limited by the pain. And so like you
mhm.
probably see just the inverse of their function on this slide, right? It just goes to,
Right, right. So I think if I let me, yeah, I don't think this study looked at functional scores, but this next study, yeah, they're looking at disability arm and shoulder here, and then you can see that kind of matches up with their pain. So absolutely, this study, we're following patients up to 36 months, and then kind of the same story there that pain and their functional scores is maintained. I like this study a lot. Again, it's also for lateral epicondylosis, or common extensor tendinopathy. And they followed their patients with ultrasound, and they can see the the ultrasound images looking more and more normal, as well as they kept following these patients after that procedure. Uh, Similar type of findings here. This study I think only went out to, I think, 6 months. But this is looking at the glute med for greater trochanteric pain syndrome, which is probably just gluteus medius tendinopathy. Again, this study looked at a couple of different areas where they did this procedure. Again, lateral epicondyle, patellar tendon, and then we can do this for the plantar fascia as well.
just a quick,
Um,
just a quick
yes,
question, Dr. Song. And that was Sonia wrote in, are you seeing insurance coverage for Tenex procedure or how's that?
yes, yes. And so these and there's so many insurance policies and plans out there, but for the most part, I haven't had there hasn't been any issues with coverage from insurance. And so while we're discussing that, so the other kind of thing that's kind of been uh, that's been talked about is kind of PRP and tendinopathies as well. And I think the evidence kind of, I'm trying to follow it, and it seems to, the pendulum seems to swing back and forth. There's definitely been studies where uh, they they do the Tenex procedure and PRP, simultaneously or very close in time together, and people have seemed to have gotten really good results with that. There was a paper out with some folks out at, I can't forget to remember the names, out in Mayo that followed that specifically, and they seem to do really well. But with PRP being, a cash procedure, I think anywhere from 750 to, I've heard up to $2,000, and so if that's definitely something that I think about with patients, and so that is kind of another thing that I really like about this Tenex, is that it's covered by insurance. Um,
Yeah, the PRP gets expensive. I've done PRP myself, but it gets expensive,
yeah.
especially if you're, like you said, it's all cash, and then some physicians, depending on the protocol, are recommending 2, 3, 4 injections of PRP over the course of
Mhm.
time. Gets pretty pricey.
Yeah, yeah. Um, and then and I feel terrible if for whatever reason they're not responding to it, and it's
Yeah.
it's um um and but I think uh for Tenex here, or needle tenotomy, I definitely think that, you know, a lot of the studies that I've seen have been, prospective studies. I haven't seen anything like a randomized control trial or anything like that on this, and so more robust studies are definitely needed to be done. I think the follow-up periods again, what does this look like in, 3 years, 5 years? Again, those studies take a lot longer and they're a lot more expensive to do. But I think, some more of those studies I think would be useful. Larger patient populations always, right?
Hmm.
Um, uh, there, uh, in terms of kind of adverse effects, I definitely have heard reports of soft tissue infection, but that seems to be about it. The protocol for post procedure rehabilitation is kind of, everyone is kind of doing their own thing, and so what I kind of do is I kind of, look at what other people are doing, what other experts in the field are doing, and I kind of, you know, uh, try to make it make sense and try to see some commonalities. But that's it's yeah, everyone's kind of doing their own thing there.
And I and
And then
I haven't seen anything standardized in the PT literature or in clinics in general. Like it's, some
mhm,
people are starting isometrics, then range of motion, then eccentrics, and then some people jump into eccentrics like week one, and then
mhm,
it's
yeah,
all over the board, and I think we won't know
mhm,
for a while still.
for a while, right, right. Um, and then the other thing that I wanted to put out there was, tendinosis is the only thing that I will use it to address. So what I mean by that is that if a patient, let's say, has common extensor tendinopathy, but uh, deeper inside, their radial collateral ligament is torn. They have arthritis in their elbow as well. It's not gonna solve those problems. And so sometimes patient selection can be a little bit tricky, in my opinion. But that's one of the limitations there as well. Um, and so just in conclusion, tendinopathies are super common, millions of patients per year, um, and that they're, I think the key is that these chronic tendinopathies, they're more of a degenerative pathology, not an inflammatory pathology. And so that has, you know, you know, not just, it doesn't change just the the terms of tendonitis versus tendinopathy or tendinosis, but more importantly, I think it's starting to change how we try to treat these. And so again, we know that the eccentric exercises are proven to remodel those the tendons, but you know, what's another way? And it seems like this Tenex procedure, this percutaneous ultrasonic needle tenotomy, is one way to try and do that. Here's some references, but thank you for having me again. And there's my contact information. I I would love to hear from physical therapists. I think you know, I see them in clinic for, you know, a couple minutes, but I think with physical therapists seeing these patients, you know, if you know, at least once a week, if not several times a week, you know, I think that I definitely would love to hear and collaborate with our therapists. You know, I think, yeah, the therapists over there at Lake Washington do a great job. I send people there all the time, I feel. And so happy to chat or collaborate anytime.
Um, great presentation, great information. I think 10x is still like on this cusp of being like a really great tool, you know, as far as like
Mhm.
it's you know, kind of acceptance as well as it's just proliferation, and then sports medicine space is gonna continue to grow, I think. um you know, one side note, do you guys do, I know you like when a PT refers people over to you, you can obviously order MRI, CT scans, contrast, pressures, that sort of thing if needed, but do you have any access to shockwave by any chance?
Oh, great question. Yeah, I don't have, you know, direct access to shockwave therapy, but that's a great point. Yeah, I don't know if you guys are aware. Also, I'd be interested to know who or where, you know, if because I think the evidence for Achilles at least is decent for that stuff. So
That's pretty good.
yeah.
Yeah, we have a couple people I can kind of refer you to that we use, but it's a nice modality for, you know,
Mhm.
for Overlake to add. You know,
Yeah.
we'll poke them. We'll poke them. Poke the administrators listening. Do you want to unshare your screen, and then we'll work through a few questions. We have some questions that were sent in, and
Does that work?
yeah, there we go. I think we're
Perfect. Yeah.
rolling. Okay, so we'll kind of run through a few of these, and I guess what, you know, first and foremost, what are your favorite? Obviously, you kind of laid out the tendinopathy. Obviously, is a really great specialty and super common, you know, thing to be dealing with. But like, what are your favorite types of clients to work with? Maybe they're sports or types of people, types of jobs, that sort of thing.
Mhm. Yeah, so I think in a nutshell, I like to be that bridge in between, you know, maybe PT, maybe primary care, and then the next step usually has been surgery. If it's not surgery, it kind of gets kicked back. And I think my goal is to try to be that in between. You know, are there any non-operative solutions for any musculoskeletal conditions? And so that's kind of in a nutshell. You know, of course, I love seeing, you know, tendinopathies. You know, and whether that tendon belongs to, a high-level athlete, to a recreational athlete, or someone just trying to, you know, get by to their day to day. I'd love to see them. Of course, like tendinopathies, you know, anything from like frozen shoulder a lot, you know, carpal tunnel, cubital tunnel, anything like that. Yeah.
I mean, I think you're a great spot for people to land. You know, either from, you know, from PT or vice versa. And on that kind of note with PTs, what do you like to see from your PTs that you collaborate with? Like whether it be communication, or if someone was to send you a patient, do you like an email? Do you like a call? Do you like just a note sent over? What kind of things what do you prefer?
Yeah, so yeah, if there's a patient that you'd like to be seen, or you want to kind of put on my radar, you know, I think an email is probably the most direct way to get in touch with me there. Yeah, so please email me. Amos.song@overlakehospital.org. Um, uh, and so would yeah, definitely would love to, discuss and, you know, see what's been done and what you're thinking versus what might be able to be done. And I definitely try to read through the PT notes when I get them faxed over. Love to see how they're progressing in physical therapy. So, um,
They can be voluminous.
right. Sometimes I'm like, where's the yeah? There's a lot of
There's a
I'm
lot of
sure
type 3 collagen sometimes in there. Um, kind of a follow-up on that, like, if you're a PT practicing, especially maybe like a younger PT getting started, when do you feel, from your point of view, when should the PT get you involved? Like, is it like a plateau of a certain amount of weeks? Is it, what would be your gut instinct to tell PTs out there, like, hey, whether it be yourself or anywhere around the country, like when should you get a sports medicine doc involved if you're kind of a PT?
Yeah, I think especially with some of these like chronic tendinopathies, if you've been working with them, and it's been, I don't know, about 3 months or so, and they're not responding to the way you would expect them to. You're wondering, is there something else going on in addition to this? Is there something else going on here? Is there something more going on here? Um, then I think that would be a good time to refer um, uh, and and see, yeah.
I think that's one of the common things you see with, therapists I've mentored over the years is that, a lot of times there's also following that physiological timeline. So I think 3 months is an ample amount of time, a sample size. But some people, I think, after the third visit of doing eccentrics, are like, well, this is just not healing. So well, it's taken a while to get there in this form too. We had another question that, was sent in during the presentation, and, maybe you can follow up on maybe in more detail, or the way that you like to use PRP in conjunction with the needle tenotomy, um, and maybe what that application looks like.
Yeah, and so what what we usually do, and so I haven't done both here yet, but what people do usually is they'll do the Tenex procedure, and at the end of it they'll draw blood, spin it down, and then uh, inject it kind of while while that Tenex after that Tenex procedure is completed. We you know probably don't inject it back into that stab incision site. Probably go at it at a different angle, but I think that when I would particularly think about that would be if there's like a lot of partial tears in there, then I kind of think that you know we have missing cells, missing tissue, and and maybe we get rid of the degenerative one and put some new cells back in there if we can.
Yeah.
So that would be kind of my thought process there. Uh, but yeah.
In any application for 10x, this was a question just sent in. Any application for 10x with arthritis?
Yeah, and so arthritis being, degenerative process of the joint, obviously, I don't, uh, I get a little bit pessimistic when I see, concomitant arthritis with the tendinopathy. You know, I don't know how well those patients are necessarily going to do because, especially if I think that their arthritis is playing a substantial role or some role at least into their pain and function there. Um, but uh, but again, tendinosis, tendinopathy being its only indication, it's kind of one of its limitations in terms of that. Yeah.
I got a couple more, and then I'll get you back to clinic. I know you got a busy afternoon here. And what is the most common age of tendon trouble that you see? And with prevention in mind, what's the best way to not see myself or you?
um, I the most common ages, I think, And I'm sure there's data on this that I just don't know. But for kind of in my experience, I feel that patellar tendon patients tend to be a little bit younger. And then the the common extensor tendon, they tend to be middle-aged. So I think it kind of depends on the tendinopathy. I think Achilles can kind of go both ways, but probably skews a little bit more towards the middle-aged 40 to 60-ish. And then I also think activity is plays a big factor too. I feel like every other runner seems to have an Achilles issue at some point. And then again, I think a lot of yeah, especially in fellowship, I saw a lot of our jumping athletes, a lot of the basketball players and the volleyball players come in with patellar tendinopathy. And then anyone that makes a living using their upper extremities, their hands, construction workers, hairdressers, seem to be prone to common extensor tendinopathy or lateral epicondylosis, which makes sense. Yeah.
It does. I think it does too, like from the standpoint when you see these as well, like when you see people come in that are that middle-aged group that you're talking about, and their posture starts to kind of change, the rotator cuff functions maybe not optimal, so then it's a lot easier just to use the elbow.
Yeah.
Whether it be pickleball or overhead work in an auto shop or anything, it's just a hairdresser. It's easier just to use the elbow.
Yeah. Well, yeah.
One last one, a couple actually for running. Okay. Any thoughts on zero drop shoes versus, say the offsets of 8 to 12 millimeters? This is a very controversial subject, of course. In terms of Achilles or patella pain, do you kind of fall in line with like what the general consensus is there?
Yeah. So I'll be honest, I don't have a great answer for that. But I did hear a talk on not too recently on kind of exactly that question, and that, does the type of shoe, does that increase or increase propensity for running injuries? And I think the studies are still inconclusive. So regardless of what type of shoe that you have, the other factor they were looking at was, are you a heel striker or toe striker? None of that seems to really have a great correlation to injury. There was some evidence that suggests that you may get slightly different types of injury if you're more of a heel striker versus toe striker, things like that. But I think when it comes to shoes and yeah, that heel strike versus toe strike didn't seem to have great evidence for leading to increased injuries.
Yeah, that's been my consensus too. It's fairly mixed. Just like you said,
Yeah.
there's so many variables too. Body weight,
Yeah. Oh yeah.
surface,
Training, mileage, et cetera, et cetera, et cetera. Yeah. Yeah. Absolutely.
With your time with the New York City Marathon, is there any specific or even general advice that you have for runners, kind of as a closing question here?
Yeah, I think with our runners there, uh, runners love to run no matter what. And I think listen to your body. Pay attention to your mileage and how fast you're increasing your mileage and things like that. Um, get seen if you're having issues, and um, come in sooner than later, and really try to listen to your body is what I would suggest in a nutshell.
Sounds smart to me. Listening to the body can be challenging.
Yeah, especially
Uh,
for a runner.
exactly. Well, hey, I can't thank you enough. It's good to finally connect with you. And if anybody has any questions or additional comments, we'll have this up on our YouTube channel. You can post the comments in the details in the section below on YouTube, and I'll make sure Dr. Song gets those questions. If it's something for PT, I'll try to answer that as best I can as well. Otherwise, we'll hope to see you again soon, and appreciate you doing this.
Oh, no problem. Thanks for having me. This is always fun.
All right, great. Thanks for everyone that attended, and we'll see you soon. All right, take care.